The data isn't there. It's not FDA approved for alcohol use disorder. I hope it will be at some point.
Try some beans in there too. In the sense of like, what do you mean you can portion control? What do you mean you're able to stop eating?
And Gen Z's like, we want mocktails. So I've seen an explosion of like mocktails and non-alcoholic things, and it seems way more normalized. So the data shows that fiber helps with heart disease, colon cancer, all that stuff.
Hello, everyone. My name is Allie Virtue. I'm the host of the Pre-Diet Podcast, and this show is all about teaching you things you need to know to have a better chance of achieving better health. The idea is kind of in the name, the Pre-Diet Show. So before you start another diet, listen to this podcast, maybe a couple episodes, give them a listen, and you're going to learn a lot about how to be more successful as you try to improve your health. And this really is a journey. It's not a destination. And I'm incredibly excited to talk to our guest today. It is Dr. Aubrey Harding. I used to work with her at her primary care clinic, Well Life Medicine in West Salem, for a number of years. And I'm so excited to catch up with her and really just get to pick her brain. Dr. Aubrey Harding is a licensed primary care physician and founder and owner of Well Life Medicine and an independent primary care and mental health practice with locations in Salem, Hillsboro, Oregon, and one upcoming in Woodburn, Oregon. A Salem native, Dr. Harding earned her bachelor's degree in psychology from Macalester College and her doctor of naturopathic medicine degree with honors in research from National College of Natural Medicine in Portland. After 11 years in clinical practice, she recently stepped away from direct patient care to focus on leading and expanding the Well Life Medicine clinics. Her clinical interests include evidence-based treatment of metabolic conditions such as obesity, diabetes, high blood pressure, with a particular focus on sustainable medical weight loss. She is passionate about helping patients move forward beyond restrictive dieting and develop realistic long-term approaches to health. Outside of work, Dr. Harding enjoys strength training, especially calisthenics, traveling, and college football. All right, let's go ahead and dive into our conversation with Dr. Aubrey Harding. All right, Dr. Aubrey Harding, welcome to the Pre-Diet Podcast. Thank you so much for being here.
Yeah, happy to be here.
All right, so one of the first questions I think we've talked about this for a little bit of background for people that I haven't talked to about this before, but I used to work for you for a couple of years, and I think the very first networking meeting I went to was BNI. And you're like, hey, I'm opening a new clinic. Do you want to join the team? And that was such a good experience right out of school. And I learned so much, even from the short time we worked together. But I don't know if I ever asked you like your background and how you got into kind of naturopathic side of medicine.
Yeah, so it's kind of an interesting story. So I used to help volunteer with sports medicine in high school, and I was like, I'm going to be an orthopedic surgeon. This is going to be so fun. And so I went to college doing all the pre-med stuff. I worked athletic training during then as well. I got really into public health, and I thought, well, maybe I should go over to primary care. And then after that, I worked in the hospital as a scribe in the emergency department. I saw how broken the healthcare system was, and I got really idealistic, and I thought maybe naturopathic medicine would be the like happy medium for it all. So I moved back to Oregon, and then I went to in UNM, the naturopathic school, and in Oregon, NDs are primary care physicians. We can prescribe, we can treat, all that kind of stuff. And so it seemed like the perfect kind of happy medium. So I got that degree, and then I worked in urgent care, and then I worked in kind of integrative primary care settings. So basically what I do is evidence-based, high quality primary care, and I worked a couple employee jobs, and then in 2017, I started a weight loss business, and then I opened up a primary care clinic, and like you said, I'm on opening clinic number 4. So we do primary care, mental health, urgent care, labs, vaccines, all over Oregon, and I really took a big interest in medical weight loss and figuring out how it was sustainable, and you seem like a perfect match, and I think our philosophies are pretty aligned as far as weight loss goes.
Absolutely, and I really appreciated your take on that, because a lot of people, I think, sometimes put me, and I'm sure that you get this a little bit as well, they see ND and they're like, oh, well, she won't, prescribe medicine, or like she'll do this or just that. And they start to get this idea. And so I'm really excited to talk about these topics because I think they're so powerful. And I think that happens once you get into the industry and see real people and meet real people and like, oh, behavior change is like really hard. And so like we need a lot of tools to help everybody instead of saying like, well, if you can't do the behavior things, like you're a failure and you don't, I can't help you. Like we need other tools to help people that aren't, able to snap their fingers and change their behavior. Because I mean, in my own life, that's harder to do than we first realized.
It's really hard, and just realizing that it's really hard and people have a lot of stuff going on and they only have so much mental energy, and you can only willpower yourself out of things for so long. And so I always take an individualized approach to patients. I kind of see what are their goals, and we talk a lot about what I call relative risk, right? What are the risks of not doing anything? What are the risks of only diet changing, right? If we tell them to change their diet and they're not set up for success and it's not sustainable, they're going to get turned off to lifestyle changes in general, and then future changes can be hard. So we always have to think about what's the risk of not doing anything or not intervening enough. And so for a lot of patients, the medications are the right option. It's not for everybody, and there's a lot of nuance with the medications. There's a lot of nuance with lifestyle and dietary recommendations. They're not all the same. So really being able to have those kind of conversations and not just get on a telehealth platform and someone's like, here you go, here's some semaglutide, have a good life, right? We have to kind of really approach all aspects as to what's going on and what they need.
Absolutely. Can you talk a little bit more about, because I don't think anybody talks about that, of the risk of doing nothing. Because I know I've gotten on calls and haven't even met the person yet. And she's like, I've been dieting for 40 years, longer than you've been alive. Why are you going to be any different? I'm like, oh, good question.
Yes.
And I'm happy to say that person is doing really, really well, because it was framed different for her and, different approach than what she'd experienced. But coming into that, that's really heavy and that's really hard. I mean, that would be hard to do that if you've been in your head. I don't think every dietary endeavor is necessarily a failure. I think you learn something, but coming into that, that's really hard to sign yourself up again. But yeah, can you talk about like the relative risk of not doing anything?
Yeah, absolutely. So we see a lot of patients at this point who are just coming for primary care. Some of them don't know they have diabetes. They don't know their cholesterol's through the roof. And so, we're kind of helping assess what's going on right now. And then, we are often, if they have metabolic conditions or they fall into the FDA approved categories for some of these weight loss medications, we are having that kind of conversation with them. Basically, for example, I'm just going to talk about diabetes a lot because some of these GLP medications are FDA approved for diabetes, and they have been since 2005, right? We're just now hearing about them, but this class of medication has been around for over 20 years, and we've been using it to manage diabetes for 20 years. So the burden of diabetes is massive, right? So long-term consequences of diabetes, blindness, dialysis, losing limbs. It's extremely expensive on the healthcare system, and just, really poor quality of life if it goes untreated. So I really do address blood sugar a lot with patients, and, we kind of talk about, okay, well, what if we don't do this? What's going to happen down the road? And so, for patients, I'm like, how are we going to intervene? Not like, do you want to intervene, but like, how are we going to intervene? And, I do have some patients that are just like, hey, you know what? I just want to change my diet and lifestyle and do all this. And I'm like, okay, I'll give you 3 months. If it gets better, great. And then if not, we're going to have a more serious conversation about like, helping them understand like why this would be beneficial. And there's risk to medications, and then there's risk to not treating it. And if someone's young and healthy, and they want to lose 10 pounds because it's summer season, maybe a GLP-1's not right for them. But, if they're 40 pounds overweight, they have diabetes or pre-diabetes and have all these other risk factors, then we're having kind of a different conversation.
When do you have, because especially with, again, I think I get planted in the wellness and definitely like preventative side of stuff. But when do you as a primary care physician get worried with like either A1C or fasting blood sugars? What's the kind of cutoff? Because I think you do take a pretty proactive approach, but what gets your attention of like, we need to start doing more about this?
Yeah, exactly. So if I'm seeing actual pre-diabetes, so let's talk about this. So one way we screen for diabetes is we do a test called a hemoglobin A1C, and a normal range is anything under 5.7. Pre-diabetes is 5.7 to 6.4, and then diabetes is 6.5 or higher. Once you're pre-diabetic or diabetic, you're technically that for life. You can say it's managed by diet and lifestyle if you get it under control, but you carry that diagnosis for life. So anytime someone's in that pre-diabetic range, we certainly have that conversation. What do you want to do? I certainly will allow patients to do intensive diet lifestyle things. We certainly talk about stuff like metformin, which also has modest weight loss benefits. And then, these days, a lot of people are coming in saying, I want these medications. And a lot of times we're putting the brakes on some of those conversations. So, we get people who I'm trying to talk into one of the GLPs who has uncontrolled diabetes, and then I have people that are begging me to prescribe it that it's not appropriate for. So I exist in kind of both realms with this.
Absolutely. Where's that range? So if they are pre-diabetic, so you said 5.8, 5.7 and above?
5.7 to 6.4 is the pre-diabetes range.
Okay. Is there a range before that where you're watching trends over time, be like, hey, watch this, it keeps going up? What are your thoughts there on where is that kind of prevention zone?
Yeah, exactly. So we always think about kind of risk factors as a holistic kind of thing, right? Are you overweight? And I know weight can be a really tricky thing in medicine. And so I usually don't bring up weight in and of itself unless the patient brings up the weight. But it is in the back of my mind, if someone is carrying extra weight, they're probably going to be insulin resistant over time, and they probably will. There are certainly people that don't, so it's not 100%, but that's something I keep in mind. What's your blood pressure? What's your family history? Do you have untreated sleep apnea? Are you smoking? Are you drinking too much? I always think about this as kind of a collective sort of what are your kind of overall risk factors. If they're generally taking care of themselves and they don't have a lot of risk factors and their blood sugar, their A1C is 5.6, I might not, have a more serious conversation. But if they have all these risk factors and their A1C is 5.5, 5.6, it's creeping up, mom and dad have diabetes, then I'll start to be more serious. So I always kind of look at these things, collectively and holistically for my patients.
Makes a lot of sense. And I think sometimes, and that's definitely another topic I wanted to talk to you about, but like, it's hard to convey. And I think I hear that a lot on the complaints of like, when I hear clients saying like, oh, my PCP didn't listen, or it's like, they probably just didn't have time. And I think that's one of the benefits when I do get time to talk to people. I'm like, this is probably why they said this. And they're not just picking on weight to pick on weight because it's the lowest hanging fruit, but in a lot of ways it is the lowest hanging fruit of like, when we get a chance to talk about the inflammation that's associated with it. This is not your doctor wanting you to look better in a bikini. This is your doctor wanting to reduce your chances of disease and inflammation. But, can you elaborate a little bit more on kind of your side of, as a PCP? Like, I'm sure you would love more time within this system to talk to people, but what's your view as a physician with your time constraints?
Yeah, it's really complicated, and the system is not set up for these good holistic sort of conversations, and honestly, like, people just don't get training. Whether you're a nurse practitioner, physician associate, MD, DO, ND, none of us get enough training in weight loss, and so when I started out doing weight loss back in 2017, I had to go do a lot of specific continuing education courses, all that kind of stuff, and at that point the weight loss options weren't as robust as they are now. So we were talking about, there are some other weight loss medications that are FDA approved that are not the GLP-1s, to a lot of people's surprise, and those are a lot more affordable. So first of all, just knowing, like, does your provider have training in this, right? So that's the first kind of question. Like, is this something you can help me with, or can you get me somewhere that someone can help me with? Because, it's hard if you try to have that conversation and they're like, I don't have any training, I don't know about these meds, all that kind of stuff. So first kind of define, is this the person that can help you, or can they get you set up with someone that can? And then, just realizing, like, if you are seeing someone that is prescribing, that is helping you, just realizing they don't have a lot of time typically. So I would encourage, more frequent visits versus like, they don't spend enough time with me. Most of them can see you several times, or if you're seeing a physician, a lot of times you can see their PA or NP in between visits, or like, hey, can we check in on the portal? Like, figure out what that kind of longevity plan is. The US healthcare system, as we all know, is very broken. And, I would just encourage people to work with what they got. So first find out, is their provider someone that can help them with weight loss? And if not, can they get them somewhere else? And if they are going to help them, what does that look like? How often am I going to see you? Try to set up more frequent visits. Trying to do like a laundry list in 20 minutes can get really dicey.
That makes a lot of sense. Okay, so asking maybe the front desk, or like what, or just how the communication schedule can kind of look, and maybe if that's intertwining some other provider visits with the MP or PA could be helpful. Because I think a lot of people just have like higher expectations. We would love to talk to, one our doctor probably every quarter, but that's just not, unless you're very proactively scheduling out like that, that's probably very hard to do, and not the norm for sure. Okay, so having that communication, would you also advise like patients like check how long their appointment is? Because I think on my end, I don't necessarily No, I'm just like, well, I'm just in there and hopefully I get my questions answered. But if I have really in-depth questions, like 15 minutes goes by like that, and you guys have things that you need to get all my vitals, update all my chart and stuff like that. And then it's, 2 minutes for my question. And I have no idea how many patients you're already behind on seeing.
Yes. And this is the eternal struggle in something like insurance-based primary care. Sometimes you can find cash-based people that you can pay and you can sit there for a long time. But in the typical model that most people are dealing with, these appointments are pretty short. It gets a little tricky when you ask for appointment times. For most primary care places, they're not scheduling like therapy where they have, certain amount of time. So I would kind of do what I call like agenda setting. So you get in there, you say, hey, these are the things I want to talk about. What are the things you're going to talk about? Can we cover these things today? And if you can kind of set that agenda, then you can make sure that you are communicating what your goals are. They can tell you what their goals are. And then you two can kind of time manage. And then you can also ask, hey, if we run out of time, what's the next steps? Can I see you in 2 weeks? Can we do a part 2 to talk about the rest of things? So again, I think more frequent visits tends to be a little bit more beneficial than trying to have long visits in today's healthcare system.
Absolutely. Awesome. Well, within a typical appointment, what's kind of your main pillars of like a healthy lifestyle that you would love to see? Like, oh, my patient's doing this, love it. They're already being a little proactive with just their everyday lifestyle.
Yeah. So when I talk to patients, we'll set meds aside. We're just going to talk about the lifestyle stuff first. I talk about it's a combination of your diet, exercise, stress, and your sleep. Those are the most things that we want to kind of focus on. I also tell them 80% is their diet, right? Like no one wants to hear that. And that's the hardest thing to change. But that's where you're going to get the most bang for your buck. So we want to make sure we're focusing on diet, but I do touch on sleep. If people aren't getting enough sleep, data shows they tend to eat on average 500 extra calories every single day. They're not getting enough sleep. So, 1 week, that's an extra pound, that's 4 pounds a month that you can just pack on just completely, unaware of it just because of the sleep deprivation. Stress management's a huge thing, right? If you're stressed out, you're not going to be sleeping well, you're going to be making poor choices. So we want to talk about stress, sleep, and then exercise. I feel like exercise is amazing for your overall health. I don't see it's an amazing tool to like lose weight. I see people that will train for marathons and they don't lose a single pound. So I do talk about exercise as an important thing for overall health and like weight maintenance, but I don't see a lot of people like losing weight from that. So, if someone's starting out, their life's, we have a lot of things to address. I tell them, let's focus on your diet. Let's make some sustainable diet changes. And then in a few weeks, we can add in a little bit of exercise. So besides medications, like those are the 4 pillars that we talk about. Alcohol is also something I want to just kind of bring up. It has a lot of calories typically. It affects your sleep, and people tend to have lower inhibitions, which makes them have poor dietary choices with that. So alcohol, for some people, that's a big thing that we can intervene, and for some people, that's not a factor. But that's the other kind of little caveat thing I tie onto diet and sleep as well.
Couldn't agree more. I see so many people that exercise so well and they're so consistent with it. They have a great split of like doing endurance, cardiovascular exercise, lifting, like all the things. They even throw in yoga, but like they're like, I don't need to sleep, or diet's just, I'm maintaining my weight fine. Like,
yeah.
And I see that so often, just a little nutrition change or like adding an extra little walk for like more stress reduction versus the calories burned. You can only burn so many calories in a certain time period. So it's the most unsexy fact. It's just like, there's just that time limitation there. Can you talk about more of like what options people have if they are struggling with alcohol?
Yeah. Alcohol, so a couple different things. So if it's just like I just have a couple extra drinks too many times, it's like, okay, what kind of other activities can we fill it in? Anytime we're trying to take something out, we first want to put something else in. It's really hard to be like, don't do this, don't do this, don't do this. So I try to focus on what I call the positive behavior. So adding something in. So do you like those like fancy mocktails they have? Do you have an alternate activity with your friends? Can you go have tea instead of alcohol? What's going on that's kind of triggering that alcohol behavior? Is it a social bonding thing with your friends or your significant other? Is it, just a stress relief? So I kind of take a step back and be like, what's the actual issue? if there is dependence issues and, people are having multiple drinks a day, they can't go any time without, going into withdrawal, that's some time that we want to talk about doing like inpatient detox or having, there are medications that can help with alcohol cravings. So definitely talk to your primary care provider or mental health provider. I know here in Salem, they have places that you can be seen same day for this sort of thing. Most of the patients I'm working with, it's just like, I have too many drinks, too many times. It's less of the dependent sort of thing. So it's kind of working with them to be like, okay, what's triggering that, and can we find an alternate behavior to, harm reduce, right? We want to have less drinks, or are you someone that needs to have no drinks, right? And each person's a little bit different with that.
I think that's so helpful because it's definitely not my scope of practice, and I can see like we can talk about like the behavior side of things of like what else can we have, or can we change up our routine, or just routine in the evening, can we go for walks instead of like planning ourselves in the front of the TV, and the TV is associated with drinks and that type of thing. But is that something, because I know GLP-1s were on our list to talk about anyway, but have you found that's a reduced craving for alcohol with some of the people on those medications as well?
Yes. So they are doing a lot of research on that right now. So we don't have hard data for this, but anecdotally, yes, a lot of my patients are reporting, even if they don't have alcohol use disorder, that they are having decreased cravings for alcohol, which is a really, really, really promising, area of research. And then I also had a patient who was, she has alcohol use disorder. She was seen at a treatment facility in Salem, and they were doing a clinical trial with Ozempic, one of the GLP medications for alcohol use disorder. So these patients were coming in every week. They were getting their injections there, and she was telling me it was pretty life-changing for her. So the data isn't there. It's not FDA approved for alcohol use disorder. I hope it will be at some point, but the data so far is really promising in that arena.
That's really exciting. And a couple clients that have struggled with alcohol abuse have mentioned this particular person didn't have a ton of weight to lose, but she really struggled with binge eating. And that's why her prescriber prescribed that as well. It sounded more like an experiment, but it worked really well for her because it quieted the food noise and allowed her to just see what life is like without those massive binges. And then she could work on the behavior stuff to like reset her routine to set herself up for success. And then I think she ended up tapering off it a little bit. But what is your experience, or has been your experience thus far? These medications have been out in the market for a lot longer than people are probably aware of. But what has been your experience so far with GLP-1 medications?
Yeah. So first I'm going to talk about it in regards to diabetes, right? Like I was mentioning, the burden of diabetes is massive on individuals, on society. You have to check your blood sugars twice a day. It affects your diet. You have to take meds. Some of them have side effects. You have those long-term things like I talked about, kidney disease, blindness, losing limbs, and stuff like that. So it is a massive burden on society. It is a huge cost. It has been very difficult to treat diabetes, and I'm not sure if you know that the rates of prediabetes and type 2 diabetes or insulin-resistant diabetes are just skyrocketing. So this is becoming a huge problem. A lot of people are walking in, they have no idea they have diabetes, and so we're dealing with this a lot. For diabetes, these GLP and the GLP-GIP medications have been completely life-changing. I've seen people's, so basically when you have diabetes, like we're talking about the A1C, you want your A1C to be under 7. That's considered well managed. And we check that every 3 months. When your A1C is over 10, that's when we say, okay, we need to get you on insulin. Insulin is a great tool temporarily. It will get your blood sugars down, but typically with type 2 diabetes, people are insulin resistant. So it's just kind of like throwing something at the wall, seeing what we can do, but it's not great long term, and insulin actually promotes weight gain. So it's something to kind of keep in mind if we're dealing with both of those sort of things. But I've seen people's A1Cs goes from 12 down to 6. Like it's been amazing. These medications have really changed diabetes management in a way I just can't even fathom. There's been absolutely nothing ever in history that has helped that. So huge, massive win for the GLP-1s for diabetes.
Absolutely.
Yeah, so it's super exciting as far as that goes. And then for weight loss, it's been, like I said, pre few years ago when Ozempic came out and all that kind of stuff, We had a few FDA weight loss medications. They were all very, very modest in their weight loss. There was one GLP-1 medication that was previously approved long before Ozempic for weight loss, and but that one has more modest side effects, and you have to do daily injections. So the weekly injections is hard enough to convince people to do, and then you have the daily ones on top of that. And it was a lot more modest than like Ozempic or Mounjaro that we're seeing these days. So they have really, really changed weight loss. I think with the GLP GIP like Mounjaro, or the other name is tirzepatide or Zepbound, that one is far and away for a lot of people a lot better than Ozempic. So I think there's a lot of good things in the future. There's another medication that is in clinical trials that'll probably be out in 2027. Its weight loss should be on par with gastric bypass. So we're seeing a lot of amazing things, and then I'm just seeing people's metabolic markers drop down. We're being able to cut a lot of other medications. So it's been pretty exciting these days.
It's incredible. I mean, because I think as a visual for people that have been around people and have seen people go through gastric bypass surgery, like the drastic results, and it's been incredible just to talk to people who have been on it, because again, like just hearing them like have more relief mentally of like such the food noise, and then being able to see kind of I guess lack of better words, but like how the other side lives, in the sense of like, what do you mean you can portion control? What do you mean you're able to stop eating? Because like I struggled with binge eating for a good couple of years, and I was like, I don't understand how you're stopping eating. There's more food on your plate, or there's more food in the kitchen, type of thing. And then you just hear that like silence, and it's incredible. But could you also talk a little bit about kind of the relative risk, or relative and also absolute risk? I know that was on our list to talk about as well, because I think those are different. And I've seen when I was in the clinic, patients bring in, I think it was an information packet on like some supplement company, and they're like, this is really going to help my blood pressure. And I remember you're like, this is going to lower it like 2 points. That's not statistically significant, but this is great marketing, like fantastic marketing. Is this a bad thing? No. Will it really make a difference? No. But can you talk a little bit more about the statistics side and what helps you drive your, decision making versus what we see on the outside?
Yeah, so I'll chat about what's called absolute risk versus relative risk, and then I'll also talk about another concept called statistical significance versus clinical significance. And I think these are both really important. This weight loss stuff is very nuanced, and I think it just requires this kind of careful lens looking at it. So absolute risk is, if we look at a medication and we say, what are the side effects, right? We're just looking at what is the risk of this medication. We're not taking into account like, the positive effects it'll have on you, or the risk that if you don't do it. So what are the risks of the medication? So those GLP-1 medications, just like anything else you do in life, including medications like Tylenol or ibuprofen, everything has risks. So for something like ibuprofen that people take without thinking too much, you can get stomach ulcers, you can get kidney disease, right? You can get these things for something like that. For Tylenol, you can get liver failure, right? It's really easy to have these terrible outcomes from these medications. And that's what we call kind of absolute risk. What is the risk of this medication? For the GLP-1 medication class, the risks that we see are, we have side effects. We have, there's very small risk in animal studies of a couple things called medullary thyroid cancer and multiple endocrine neoplasia syndrome type 2. So those medications can trigger that. And, there's side effects like I talked about, like, we can get upset stomach, we can get some bone mineral density loss, we can get some, some muscle loss. So there's stuff like that people get from those medications. They're not totally sure if it's due to the weight loss in and of itself or the medication. So I just want to kind of throw that out there. You'll hear lots of sort of stuff, and most of those things can happen from rapid weight loss, regardless if it's from medication or diet changes. So that's kind of like the absolute risk. The relative risk takes the patient into account. Okay. Patient A, you have pre-diabetes, you're about 40 pounds overweight, mom and dad have diabetes, your blood pressure is creeping up. What's the risk of taking the medication? What's the risk of not taking the medication? And you take that difference or delta, and that's what we call the relative risk. And so we always want to look at the relative risk, because there's a risk of not intervening, right? And so I spend a lot of my time explaining that to patients, and I just think it's a really important concept and something that's not talked about enough with these medications. So we always need to look at the relative risk, because there's always risk associated with doing nothing or not intervening enough.
Absolutely. And I think a lot of those especially with just like the severe appetite restriction, like if you go on a crash diet, you're going to lose a lot of muscle as well. And so a lot of things that you can pair with it. For me, I always think it just sounds like training wheels from my non-prescribing lens, obviously, of like, this allows you to go on more walks, it allows you to moderate your portions, if it allows you to feel more energetic and like see weight loss progress, and it gets you in the gym, and then we can add in some weightlifting to combat some of the muscle loss or the bone mineral density loss, like all of those things, I reasonable. It sounds like very reasonable as far as like side effects go, because like a lot of those lifestyle can really help, and we need lifestyle, those components anyway, if you're on the medication or not. That's kind of general requirements of being a healthy human.
Yes, yes. And a couple other things. One thing is I don't try to gatekeep. Sometimes people, like I've heard other providers be like, well, this person's not doing this, so I'm not going to prescribe it. And I'm not a big fan of gatekeeping, right? So we want to think about a concept called harm reduction. How can we meet that patient where they're at? How can we improve their life? Some patients are just not going to do the diet and lifestyle things. And you know what? I can still improve their blood sugars and their health outcomes by prescribing these medications. Obviously, we want to kind of, try to address the lifestyle stuff as much as possible, but I'm certainly not going to withhold the medications just because they're not doing that if they, meet the FDA indications for those meds.
Absolutely. Can you also talk about statistically significant and then clinically relevant as well? I think we skipped over those ones, but that was a really great point.
Yes. Okay. So, there's a concept of statistical significance, right? So we're saying, hey, there's an actual difference. This medication, this lifestyle intervention, this whatever has a difference. It actually helps. But like you were saying before, sometimes it can be not clinically significant. Okay, it decreases your systolic blood pressure 2 points. Is that going to change your outcomes, right? Yes or no? So sometimes people can have creative marketing that says, oh my gosh, this is statistically significant, this changes this, and we have to look at what's the clinical impact, right? So we don't want to put a bunch of people on medications that don't have a clinical significance, even if they had a statistical significance. So that's just a little nuanced thing as far as like, is it significant? Is it statistically significant? Is it clinically significant? And we just want to make sure we're having a good, positive clinical significance before we're, using an intervention, whether it be medication or lifestyle.
Absolutely. And then when you're looking at GLP-1s, there's a lot, like you mentioned, there's a lot of variety as far as GLP-1s. So how do you have a conversation if someone maybe has tried one, they're like, oh, no, that didn't work for me, or it made me feel awful. I've definitely heard that before. A friend's mom has tried it before, made her feel really awful. I think she suffered with constipation. But like we talked about those other side effects, like there's so much lifestyle and other things that you can do to help that. So again, it allows this potentially life-saving medication to have a chance.
Yeah, and people come in, I want this because so and so took it, or this happened with this medication. And again, it's getting into the nuance and the details. Okay, what happened? What was your dose? How long did you take it? So it's kind of like figuring out, okay, what, were you just like, did the dose escalate as fast as possible and you had side effects at the higher dose? Was it starting out? Was it tolerable? Was it not? So one thing I talk about with patients when I'm starting a medication is, what are we going to expect here? And I think if you set up those expectations, they're a lot more likely to stay on it, for it to be able to help. As with several medications, the GLP-1s tend to have side effects at the beginning that tend to resolve over time. So if you have that conversation with the patient, hey, we're going to start you at this starter dose. We're only going to increase as you tolerate it. You're going to let me know. You might have heartburn, you might have some constipation. If it's tolerable, keep taking it. You can do over-the-counter stuff to kind of help with the side effects, but just keep taking that same dose until you're doing okay with it. And then we can increase the dose. So it's making sure that the patients know what to expect, because if you don't have that conversation and then they're having explosive diarrhea, they're stopping that medication and they may not come see you ever again. So it's just kind of setting up what to expect, how to manage those, what to do if it's unmanageable, and just having someone that can work with you on those nuances.
Another question I had about it, because I think this was a couple of years ago, and as these were getting more popular, but it seemed like the providers wanted to increase at a pretty steady rate. It sounds like now it's a little bit more cater to the person of like, hey, I'm happy on this dose. Like my appetite is perfectly regulated. I don't have any of those symptoms anymore. Was that just early recommendations or early training that we're trying to like increase dose on a regular basis? And has that changed at all?
Yeah, it's a good question. So what's FDA approved is those kind of monthly dose escalations for the two main ones that we're prescribing right now are Ozempic, which the active ingredient is called semaglutide. That one is also available for weight loss. So Ozempic's approved for diabetes. Semaglutide is the active ingredient, and then Wegovy is the name of the weight loss approved one. So these medications have really specific brand names and FDA approved indications. So if you have diabetes, you'll have to do Ozempic. If you're doing it for weight loss, you have to do Wegovy. And the other one that I prescribe a lot is tirzepatide. For weight loss, for sleep apnea, it's approved as Zepbound. And then for Mounjaro, it's approved for type 2 diabetes. So that's the first thing that we kind of talk about is like, which one we're doing. So those are the two ones that we mainly do. And those have a monthly dose escalation. So I think initially everyone was just trying to follow the kind of recommendations. I think that people are like, okay, we can slow this down. So I wonder, are we meeting their expectations? Are the blood sugars getting better? Are they having side effects that are tolerable? That kind of thing. So for me, I don't put refills on these medications. I make my patients at least portal message me every month. This dose is good. I want to slow down so that we have like a, consistent eye on what's going on.
Makes sense. Is there slightly different mechanisms of action as far as for the different ones, like sleep apnea versus weight loss? I would imagine be slightly different.
Yeah, so it's a good question. So there are several what we call just GLP-1s. So it's glucagon-like peptide 1 agonists. And so those are your Ozempic, that's liraglutide. There's a couple other ones. Those have been around since 2005. And then the more newer ones, the tirzepatide, it's a combo one. So it's GLP-1 and then GIP-1. And so that's, glucose-dependent insulin-tropic polypeptide. So it's a mouthful, and so that one tends to have less side effects and a little more efficacy as far as the weight loss goes. Ozempic is approved for diabetes, and then its counterpart Wegovy is approved for weight loss. They're the exact same medication. They're all semaglutide. They're exactly the same. Tirzepatide approved for weight loss is Zepbound, and for sleep apnea, it's that GLP-GIP. It's exact same as Mounjaro that's approved for diabetes. So it's all about patents and FDA approvals and insurance stuff. And so sometimes the insurance will be like, well, they have diabetes, don't prescribe Zepbound, but we'll cover Mounjaro. And so it's a lot of insurance game, but they're the exact same thing. They just have different brand names and different FDA approvals, which is maddening, but it is what it is.
Gosh, what a headache just to keep track of, all of the game besides outside of actually just talking to your patient and finding the right fit for them. What do you talk to your clients about when they ask like long term? Because I had a client had a really bad experience. She was doing all of the healthy things, probably mid 40s, and she lifts weights regularly. She does put on muscle mass well. So she was one of those few people. She's like, I usually don't say this, but like, I don't want to get bulky. And she's like, I add a lot of muscle very quickly, probably genetic component to it. Does CrossFit, goes on long hikes, eats relatively well. And she had a conversation with her provider about a PCP. And I think she had a conversation with the resident, and the attending kind of blew her out of the water in the sense of like, well, you're just going to gain it back when you stop. So why are you going to do this now? And she was just kind of, put on her back feet like, oh, I don't know anymore. But how do you have that conversation about long-term effects and like getting the best possible result for that person?
Yeah, it's a really important question. So the data show that with Ozempic or semaglutide, you go on it, you lose all your weight, you stop it, and you tend to retain a 5% body weight loss. Tirzepatide or Zepbound or Mounjaro, that one tends to be 10%. So the data generally shows that if you go off the medications, you will regain a lot of the weight back. That being said, it just kind of depends on the patient. And are you making sustainable diet changes? Can you maintain your weight? Do you want to be on it all long term? For some people, again, this is that relative risk category. it's beneficial for them to stay on it, right? Like they're going to keep their diabetes risk in check. They're going to keep their weight down. They're going to keep their functionality up. So for some people, it is the right thing to be on it lifelong, but it's having those nuanced conversations. Does this make sense for you? It is absolutely FDA approved for lifelong use. So there's no inherent problem as far as, being on it forever. Like I said, we've been using these medications for over 20 years for diabetes. I know people are like all worried about the lifelong use, but we have to look at the relative risk, and the data we have, which we have about 20 years, it's pretty darn safe. But it's a cautious conversation. And one thing that we haven't talked about is cost of the medications. That is the biggest conversation I have with these patients. There's a lot of people that want to be on it, and they're like, I can't afford $500 a month, right? And so then it's like, okay, well, what do we do? How do we manage this? Medicare just came out with a thing this month saying that they will cover it for certain conditions for $50 a month. So I think better things are kind of coming down the pipeline, but cost is a massive thing that we talk about as far as kind of long-term things. I ideally want patients to make those diet and lifestyle changes and get those training wheels going so they can sustain it. But for some people with the food noise and with diabetes, pre-diabetes, like it is better for them to be on it long term.
Makes a lot of sense. What patients come to mind, and again, looking at their whole picture, that maybe aren't the right fit? Are those the people that don't have a lot of weight to lose or are still kind of borderline as far as type 2 diabetes?
Yeah, who's not a right fit? I think so the first thing I look at is what the FDA has approved. It says this is the patient that's appropriate for it. If you're prescribing it for people that don't fit into that category, it's called off-label prescribing, and it's a little riskier. And this is true with depression medications, all kind of medications. There's FDA approval, and then there's what we call off-label prescribing. So the first thing I look at is, do you meet one of those FDA approved criterias? And then if yes, I'm generally good with it unless they have, these family histories of these rare conditions. If they don't have one of those FDA approved conditions, I think about, okay, do they have other risk factors? Technically, these medications are not approved for pre-diabetes. But if someone's A1C is 6.4, they're just one step from being diabetic. So, I'm not going to be like, no, this isn't appropriate for you. So first thing is the FDA approved indications. And if they don't, then I say, are you on the borderline? Do you have other risk factors? Do you have other things, like maybe they're pre-diabetes and they've been working out and eating healthy and it's just creeping up, then we can kind of have those conversations. So if they have the indication, yes. If they don't, we look at the risk factors. The people who are generally not appropriate for it are the people with no risk factors. Their BMI is close to normal. They just want it for athletic endeavors. We have different conversations about how we're going to kind of approach these problems. Because again, we have to look at the relative risk, and there is some risk with the medication. So if you have no risk factors, your BMI is normal or close to normal, there's not a lot of benefit from you taking that medication, but there is risk. And so we go back to that relative risk conversation for both sides of the GLP conversation.
So helpful. And it makes me think of especially if they've tried dietary things. I mean, some things like, honestly, therapy. If it's like poor stress management that causes us to maybe, and it's harmless snacking or generally harmless, I don't know if that's the right term, but like occasional alcohol consumption, right? If those and especially someone who's maybe like 20 to 10 pounds overweight. And so it's not necessarily, 20 pounds is pretty significant, probably metabolically, but like less than that, it's you're not worried about them as far as like long-term risk of chronic disease as much for those particular people. But could certainly look at some other options as far as therapy or like hiring a different coach as a different outlook on behavior change and things like that. That makes sense.
So I always try to meet people where they're at. Okay, what's your actual issue? Because they come in, they say, I want a GLP. And I'm like, okay, let's take 3 steps back. What's going on? I understand that's the conclusion you came to, but like, let me see what the problem is. And then I can give you, my approach to the problem, which may be your same answer and it might be different. So that's kind of what I do when people come in asking for something in particular.
Like, what advertisement did you watch? No.
Exactly.
Excellent marketing.
Mm-hmm.
Can you talk a little bit more about what makes Well Life Medicine a little bit different? Because you guys have a really big mental health component, but what else kind of sets you guys apart?
Yeah, so I own and I founded Well Life Medicine, and we do primary care and we do mental health. So we have 5 psych nurse practitioners. So psych nurse practitioners do psychiatric evaluations and medication management. So if you think you might have depression or something's going on, you'll have an intake with them. They'll say, okay, you have this condition or that. They'll talk to you about the medication options, and they can treat you for those sort of things. We also have 2 soon to be 4 therapists. And so the therapists do more like talk therapy. And so a lot of times we're doing those kind of hand in hand. So we have primary care. We have 5 days a week. We have walk-in, what we call express care. So people can walk in. They can be seen for one issue, whether it's a cold, UTI, I just moved here, I need my meds refilled, that sort of thing. And then we do like labs, vaccines. And so we try to be kind of one-stop shop. We do a lot of collaboration with the providers. So every week we get together, we talk about difficult patient cases. We do kind of like warm handoffs. We like if I have a patient and they're having some mental health stuff going on, I'll message one of the psych NPs, hey, I'm seeing so-and-so, they're going to see you in 2 weeks. I think this is what's going on. Like, can I start this? And they'll be like, yeah, sounds great. And so we're able to like give them a lot of heads up, and we're able to get people in right away for, mental health services or procedures or urgent care stuff that we need. So we try to be very accessible to our patients and just really address all of their needs, whether it be mental health, physical health, or just, social issues going on, right? What are other barriers to your care and your health? And, we have a community health worker who can meet with patients if they're having logistical issues as well.
Amazing. That's so comprehensive.
Yeah.
That's awesome.
Yeah.
So good. Okay. Well, let's see. A couple closing questions. What advice would you give to those just starting or potentially restarting a health journey, health campaign? So hopefully this is their last restart, but what advice would you give them?
Yeah. So I would just say this is a lifelong thing, right? I always think about what can you do forever? What kind of changes can you make forever? Because I have patients, they'll go all in, they'll lose all this weight, and then they stop. And then they gain it back. And that cycle can be really difficult to get out. And it takes a really big emotional toll on folks when they're gaining weight and losing weight. So I would rather them make a small change and they're sustaining it. I also would encourage them to look for modest results, right? I don't want them losing 20 pounds in a month. I want them losing about 4 to 7 pounds a month. So we want slow, sustainable weight loss, and just realize one day, one meal, one whatever is not gonna, you didn't gain all this weight in one day. So you're not gonna lose it all really quickly. So long-term sustainable weight loss is kind of where we want to see. If you have a rough day, rough week, rough month, just jump back in, and it's more about what you do long-term. We don't need perfect. We just need good enough. And when you're looking at your diet changes, if you can find the smallest calorie deficit that is sustainable, that's where I want you. I don't want you cutting out a bunch of calories and being starving and binging later. We want the smallest calorie deficit that'll get you that 4 to 7 pounds a month. So that's kind of the kind of overview thing is long-term sustainable, and don't get discouraged if the scale goes up. Some people like weighing themselves every day. Some people don't like it at all. Some people once a week. But if you're an everyday scale wearer, it's gonna go up and down depending on water and salt. And so just don't get discouraged based on a reading here or there.
Agreed. I saw that in probably I think it was like a women's Facebook group, but someone was talking about that, like, oh, you should only weigh in once a week. And from tracking information from clients, I find it fascinating that the trends that happen. And overall, because nobody is probably as nerdy about this. Certainly clients aren't as nerdy about this, but I'll track their average if they do get a weight, at least 5 for the week, and track their average. I'm like, you're 1.5 pounds down from last week, but I know today you're the same weight as you were last Friday, but you would have missed all of these lower numbers. It's just the weekend that usually puts it up. So Monday doesn't always look like your best weigh in, but Friday or Saturday is sometimes your lowest weights for the week. And that I find gets people really numb to it. Hopefully, obviously a lot of talking around that of like, it's fine, it's normal. This is your normal range of fluctuation, but also like the trend is going. So like, we did great. We don't need to be perfect. Like you said, I think that's the smallest, most effective dose as far as the calorie deficit is just like so magical and underrated.
Yes, yes. And I know you talk about this a lot, but fiber is something I talk to my patients over and over about. Protein is getting its moment. That's great. We need protein, but fiber is like the most
Fiber is coming up.
overlooked. Yeah, it is so overlooked. So figure out where you can sneak in some fiber, slow, steady. It helps all of your health outcomes, colon cancer risk, heart disease, everything. So the more fiber you can get, but just slow and steady, and get some advice on logistics. But fiber definitely needs its moment.
Absolutely. Do you have recommendations as far as fiber supplements, or what's your opinion on those? I mean, I like a food first approach, but I recognize that it's hard for people, especially like while they're making those changes and learning what foods are high in fiber, what ones kind of aren't. That's usually surprising that people are like, I had a big salad and it wasn't that much fiber. I was like, I know it's sad, but try some beans in there too.
Yeah.
But what's your take on helping clients like increase their fiber?
Keep it simple, right? Find something that you like and stick to it. So the highest like bang for your buck items you're gonna get are chia seeds, ground up flax seeds, and psyllium husk. Those are I don't think you can get more fiber for as less grams than those guys. So some people hate chia seeds. Don't eat chia seeds. If you're fine with the psyllium, go for the psyllium. So keep it simple, keep it easy, keep it routine. When I'm working with patients with like weight loss stuff, pick 5 to 10 meals and just stick to those. Eat the same breakfast every day or the same 3. So they have whatever calories they have, the general macros, stick to it, make it easy on yourself. Trying to have willpower day after day, meal after meal, like it's just exhausting and it's not going to work. So find yeah. So figure out what it is. If you like frozen raspberries are amazing source of fiber. Keep them in your freezer, throw them on your yogurt every day. If you are a chia seed person, just be like, I'm having 2 tablespoons every day. Whatever it is, just make it easy and stick to it, and find something that you don't hate to do every day.
Don't do things you hate. It's not necessary. I had one client that I thought was so genius. She would make chia seed pudding. So it's just chia seeds soaked in whatever water, almond milk, put a little bit of vanilla in there. She might have put some maple syrup, but a negligible amount. And she just had like 2 big spoonfuls with every meal. It's kind of like literally this fiber supplement. She was finding it hard to eat enough of the fiber stuff. It was just filling her up so much. But like you said, 2 tablespoons of just like and you could do the same thing with chia seeds. It's just like a big spoonful and it lives in her fridge. She makes the batch for the week and that's it. And it was like, I think just from chia seeds, it was like 24 grams of fiber added to her day, not including anything else from her meals. And I'm like, yes, that's amazing.
Yes. Yeah, no, it makes a huge difference. And I've seen people, have their LDL or quote bad cholesterol drop like 60 points just from 40 grams of fiber a day. So obviously check with your healthcare provider. Like, I'm not giving any medical advice, but it's something that can make a big difference. And the data shows that fiber helps with heart disease, colon cancer, all that stuff.
Amazing. Lastly, before I ask you where we can find all of the well life medicine related things, one of my favorite questions to ask people is, as in our culture that makes it very normal to just be very unhealthy, it's very common, what would you like to normalize to help our whole population get healthier?
Oh, and one thing that I think Gen Z is doing really good is they're normalizing not drinking alcohol, right? Like I'm a millennial. Yeah. What we do is we go out and there's drinks here, drinks there, all that kind of stuff. And Gen Z's like, we want mocktails. So I've seen an explosion of like mocktails and non-alcoholic things, and it seems way more normalized. So that I think is going to have a massive impact on everyone's health. So if we can shift towards activities that are not just alcohol centered, I think that's going to really impact everyone's health overall.
Agreed. All right. Well, where can people reach out? You have clinics in what areas? What's the best route to reach out if someone's looking for mental health services or primary care services?
Yeah, so we have 2 clinics in Salem, one in West Salem and one in Southeast Salem, and then we have one in Hillsborough, and we are opening one in Woodburn in the fall. And we do lots of telehealth. So if you're anywhere in Oregon, we can help you out. We take almost all insurances. We have reasonable cash pay rates if you don't have insurance, and we do primary care. We do a lot of medical weight loss, so we can help kind of chat with the nuances with all these meds and help you get you on the right track for everything. So you can check our website, welllifemedicine.com, and go from there.
Awesome. Thank you so much, Dr. Harding, for being here. This was an amazing question. I don't think I've ever gotten through almost all of my questions before, and everything was answered so thoroughly. This is just making my brain like so excited for people to hear.
I think I talk really fast, so hopefully
you crushed it. You crushed it. Absolutely. Thank you so much.
Awesome. It was great to be here. Thanks for having me.
All right, that's what I got for you today. Hopefully you enjoyed that conversation with Dr. Aubrey Harding. Before you go, make sure you are following the podcast wherever you listen to your podcasts. Subscribe on YouTube, like this episode, give it a rating or review. All of those things are totally free and easy to help us grow the show as well, so more people can learn how to be that little bit healthier. If you're interested in more resources, make sure that you subscribe to the email list. That is the Free Ship Friday email list at parksidenutrition.com/subscribe. And I'll email you free resources to help you along your health journey every single week. All right, that's what I got for you today. Thank you so much for listening to this episode, and I will see you in the next one.